Dr. Kadir. And shall we begin with the session? Okay. So without much delay, let me first explain you why this topic is very important. If you go through the real-time statistics, look, nearly 23% of the death happening is actually in road traffic accident. So if you take up the overall death of the world, 23% is happening because of road traffic accident, only 3% in war, and suicide is 15%. So the huge proportion, nearly 1/4 of every death is road traffic accident. So in that case, it is mandatory for you to have a knowledge about these road traffic accidents and how to manage a trauma, which I feel is very, very vital. So that is a simple reason why we chose this topic. Okay. And whenever there is a trauma, whenever there is an orthopedic resident, everyone is thinking only about fracture. But remember, before reaching the fracture, most of the time you will lose your patient. Before reaching to the management of the fracture, you will lose your patient simply for the reason that you may miss what is called basics. What are all the most life-saving complications that you actually missed during those crucial golden hour that in turn lead on to the death of this patient? If you don't agree with me, then go on to the next statistics. If you look into this statistics, see the first few hours of death. Okay. If you look into this statistics, the first few hours of death is the one which constitutes the maximum number of death happening following a trauma. Most of the time, most of the death actually happens right at the incident, right at the time of the injury itself, right at the site of the trauma itself. So whenever there is a trauma happening, just a minute. Could you guys see me, my incarnation? Yes, just respond. Okay, so whenever there is a trauma, remember at the site of injury, there is a peak. At the site of injury. And another possibility is within few hours. So these two things, if you manage within few hours. And the third peak will be after a few days. So third peak will be after a few days. Days to weeks. Okay. So what we are trying to say is, you cannot do anything to control this. You cannot, and the crucial number of death is actually happening within the first few hours, and it can be prevented. 50 to 60% of such death can be prevented if you meticulously intervene in that time. Okay. While the third peak is drug related complication, infections and other things. Okay. The first site, the commonest cause for the death at the site of injury is head injury. While the second peak, which happens within the few hours, is because of collection of fluid or air. So whatsoever collection into the compartment is the reason. Is because of collection into the compartment. That is the cause in the second peak. The third peak is because of infection. His third cause is due to infection or organ dysfunction. Or metabolic. So from this slide, what we need to understand is most of the death can happen right at the site of injury itself. Point number one. And the most common cause for such death is head injury. You cannot do anything to save this patient because these patients are heavily traumatized and the patient is already died, and you cannot prevent this death except by asking the patient or by creating awareness that you should wear helmet, you should avoid consuming alcohol while you drive, and you should wear seat belt. These are all the only preventive measures that you can do in order to control the death at the site of injury. The second peak happens within few hours, I said, and that is because of collection into the compartment. Collection into the compartment, in a sense, it may be air, which is pneumothorax or pneumoperitoneum, something like that, or it can be blood, hemothorax or hemoperitoneum, something like that. There is some collection which is happening in some compartment of the body, intracranial bleed, or there is a bleed within the musculoskeletal compartment of femur or something like that. So that is what called as collection into the compartment, and that is the that constitutes a major bulk of death which happens in the few hours. The third peak is because of infection, organ dysfunction and metabolic etiology. And why this seminar or workshop is actually planned is to handle the second peak, that is the death within the first few hours, because that is more preventable. And if you plan meticulously within the golden hour of 1 hour, okay, and if you are prepared well, if you are having sound knowledge, and if you intervene properly without missing any step, you can prevent this death nearly 50 to 60%. So that is the reason a huge proportion can be prevented, and that is the reason why we are organizing this symposium. And look into the causes of death also. So if you look into the cause of death, the green one, CNS cause, as I said, CNS causes, the head injury is a predominant cause of death, and next only to that is exsanguination, which means loss of blood is the next cause of death. Okay, but based on various fracture pattern or based on various injury, this predominant cause of death may vary. Okay. So what is more important when you are handling patients with trauma? The teamwork. And most of the candidates who are listening to this workshop, I hope they are MBBS students. Okay. So more than knowledge, please understand what is called as teamwork in trauma management. Okay. So it is vital for you to understand what is called as teamwork, because most of the time you will be the one who is in the front end. For example, you will be sent in an ambulance to the pickup point where there is an injury or an accident happened to a patient. Okay. In that case, you will be the one who is handling the patient right at the in the front end, and you should be in a position to convey a proper information to your primary center where this patient is going to reach first. Similarly, the primary center person should be in a better position to inform this to a consultant. So there must be a proper communication, and the penetrance of the communication should be very, very important. What are all the things you should say, what are more relevant and what are irrelevant? Okay, so all these things has to be given more importance. And though we may talk about protocols like whether it should be a CAB or ABC or whatsoever the protocol that we are going to discuss near time, see, it need not be only sequential. When there is a multiple people available, one can take care of airway, another can manage with the breathing, and another can manage with the circulation, thereby saving a lot of time. Okay. And more than teamwork, the next important to teamwork you need to know is preparedness. Prepare. Okay, you need to prepare well. For example, whenever you receiving a call, there is an accident that this patient is going to come to your center, please make sure whether your center is capable of arranging or managing this patient. Okay, how? You must be having all equipments to correct an airway, right from the oral tube or the nasal tube or from the ET tube or the tracheostomy tube. In case of difficult airway intubation, you may require medications like succinyl CoV and etomidate. So many things. Okay, so many things may be required. In that case, are you well equipped? That is very important. Second, are you having the concerned specialist? There may be a person who is having a severe airway injury. Do you have a person who is capable of intubating this patient? If you are suspecting a difficult airway, with the expertise available to you, is it possible for you to handle this patient? So prepare yourself. Make sure that you have all equipments, you have all infrastructure, you have all manpower required to handle such patients. If you are incapable, please make sure right at the beginning when you are receiving a call there is such patient, please inform them. Thereby, this call will be diverted to some other place where it is actually capable. Okay, why I am telling all this is simply for the reason The first 1 hour, is the crucial period. The first 1 hour is the crucial period. So if you handle the patient perfectly in this 1 hour, the chance of you rescuing the patient and giving him a big life is very, very, very high. Okay, so that is the reason why we are more bothered about the teamwork and your preponderance. Okay, you should make sure that you are having infrastructure. Okay, and the next thing, preponderance is not only having the resources. Okay, organizing the resources is very vital. So if you are going to be a part of a team, okay, and you are receiving a call that so and so patient who is sustained a road traffic accident is going to reach you, okay, reach your hospital, then it is your duty to inform your subordinates, like nursing people and other auxiliary staff, that so and so people is going to come. Make sure all the products are working. For example, the ET2, the syringe, everything is available or not. Okay, and make sure everyone is prepared also the in a protected way. For example, considering this COVID pandemic, there need not be a pandemic event. Whenever any patient coming to you, please make sure that you are following an universal precaution. Okay, universal precaution. So the third important thing is universal precaution. So that is very, very vital. Universal precaution, that is very, very vital. So what are all the things that you should know? Teamwork, prepare well, and also make sure that you are organizing every member in your team to follow universal precaution, and everyone should follow a same order or protocol, And why everything should be this much organized? Simply because there is something called as a golden hour, and that golden hour is only 1 hour. So if you do your best in that golden hour, this candidate is going to this patient is going to be rescued, okay, and given a life, Now, let me frame a scenario. Assume that you are a junior resident and you are in the ambulance and you are reaching a road traffic accident site. Okay, and there is a patient and who is in the middle of the road. So the traffic is also halted. So your scene safety is ensured, that your scene is safe, and you are going to the patient. Okay, and you are evaluating the patient. After initial evaluation, you should make a call to your center, that so and so patient in so and so way. Okay, what are all the things that you will inform your higher center? Okay, you should know that. You cannot say a 21-year-old male, I think he has gone with his wife, sorry, 21-year, okay, a 28-year-old male, he is riding with his wife and sustained a fall, and I could see some apples and oranges from the bike, which has been splashed all over, and I could see the bike is still, the engine is still running. All these things will become irrelevant, and the other thing is there is a small aberration which is present over the cuff, and there is an aberration over the forearm region or arm region. All those points will go irrelevant. So what are all the things you should say? What are all the things you should not say? You should know. Okay, for which we follow a mnemonic called as MIST. We follow a mnemonic called as MIST. What do you mean by MIST? In which it's actually an acronym in which M stands for mechanism, mechanism and the time of injury. Okay, so when you are starting to communicate to your higher authority, it should be like this: a 27-year-old male who sustained a road traffic accident, a lorry versus two-wheeler, 3 hours back, lying in the road. Clear? So that's how. So what is a mechanism? Why that lorry versus two-wheeler is important? Because to assess the velocity of injury. So the your higher consultant or whomsoever is in the trauma center is listening to you now can have an assumption this is an young male and who sustained a high velocity road traffic accident. Okay, and the next. So now you told the mechanism and the time is he having this injury 3 hours back, which means he crossed the golden period. He already crossed the golden period. Okay, if it is going to be 30 minutes, okay, then go. Injuries found and suspected should be informed. Okay, there is a heavy bleeding in the head, there are multiple contusions, and there is an open puncture wound present in the chest, and there is a severe discoloration in the abdomen, and there is a deformity in the femur. So what does this message convey to your higher authority? That this patient could be a victim of an head injury, chest injury, abdominal injury, and also possibly a musculoskeletal injury, which may be a femur fracture too. Okay, so first inform the mechanism and time of injury. Next, inform what are all the injuries that is found, or what are all the injuries that you are suspecting. So that is second. And third, what are all the symptoms this patient is showing right at the time when you are seeing, and what are all the signs. So that is called as the symptoms and signs. So with related to symptoms and signs, this patient is sounding conscious, and this patient is having is having a labored breathing, and there is a broken tooth, and there is he is telling or complaining of severely pain in his thigh, and their abdomen seems to be bloated up. So these are all signs and symptoms which will convey definitely this patient is having an airway compromise possibility is there. There is a broken teeth, and there is an open injury into the chest, and there may be a pneumothorax or a hemothorax, and the bloated abdomen, possibly a hemoperitoneum, and this patient is having severe pain in the thigh. And comparing it with the injuries which is previously presented to you, the possibility of having a femur fracture is quite high now. Okay, so the third thing you should say is signs and symptoms. The fourth thing that you should convey is treatment initiated. The fourth thing, another important thing that you should communicate is the treatment initiated. Okay, so that, for example, a treatment initiated, by which what we mean by the word treatment initiated. See, you are the one who saw this patient right at the time of the injury, and you are telling this patient is having a femur fracture, this patient is having a bloated abdomen, and this patient is having a multiple contusion and chest injury, and this patient is having a head injury possibility, and there is an airway compromise. So you may be skilled enough to rescue an airway right at that time itself. You may be skilled enough to start a IV line right at that point itself. You may be already trained with the ATLS protocol, that you can follow such protocol right at the site of injury to manage some of the injuries. Okay, in that case, whatever the treatment you did, you should inform that to your higher authority. Okay, thereby they will be prepared to ensure an advanced treatment what is needed now, rather than preparing IV line. If you already put an IV line, they will prepare something else. They will try to inform their blood bank to make sure the proper blood is available or not, something like that. Okay, so whatever the treatment you have given, you should inform it to your higher authority. So remember the four things whenever you are conveying a news of injury to your higher authority, or your consultant, or to the trauma in charge person. Remember the four things that you need to tell is mechanism of injury, what are the injuries found and suspected, what are the signs and symptoms, and what are all the possible treatment options that you have done to the patient. Okay, so all these has to be informed to the your concerned in charge. Now, another big time question that you all will have is whether with related to a trauma management, is it an ABC or CAB? Okay, so as per advanced, as per recent, all these explanations, many times when questions are framed in that way, some people may answer CAB as a sequence, but remember CAB is a sequence for ACLS, which means advanced cardiac life support. Okay, but what you are handling now, what you are discussing today, what we are managing is trauma. So when it comes to trauma, remember the sequence is always A, B, C. The sequence is always A, B, C. So what is right, what is wrong? ABC is right and CAB is wrong. Okay, so always it is ABC with related to advanced trauma life support. It is CAB, maybe it may be CAB if it is an advanced cardiac life support. Okay, but now what we are handling is an advanced trauma life support, and the treatment sequence should always be airway, breathing, and circulation. Airway, breathing, and circulation. Okay. Now, so what do you mean by A? The word A indicates it is not just airway maintenance. The word A not only indicates airway maintenance, it indicates airway maintenance with the restriction of cervical spine motion. Why this word is important? Okay. See, if you are going through A, B, C, then D, then E, all your primary survey is over. Then only in a secondary survey, when you want to assess the log roll, at that time only you are going to examine the spine, unless the patient is in a shock. Okay, if it is in the shock, then you will find it as right in the C itself, you will find that there is a shock, and what type of shock, neurogenic shock. If there is, then you will think about cervical injury. But otherwise, to palpate the spine, before doing that, you always need to complete the primary survey in sequence. Okay, if that is correct, while doing the airway maintenance itself, if there is a cervical injury and there is an impending instability, by maintaining the airway itself, you can cause more damage to the C-spine if you are not prepared well to immobilize the spine first. So what I'm trying to say, airway maintenance is more important, but at the back of the mind, always assume that every patient, every trauma patient who reaches you is having a cervical spine injury. Okay, always assume that all your patients are having cervical spine injury, that until proved otherwise, they are all having a cervical spine injury. And whenever, even just to remove a helmet, make sure whether you stabilize the cervical spine. Okay, you may begin with all your management even before a very simple thing of like removing the helmet. Make sure that the cervical spine is stabilized. Just don't put on ET tube without stabilizing the cervical spine. At last, you may get a patient airway patent, but because of the cervical spine injury and the diaphragmatic damage because of the paralysis, the patient is not going to have really a good prognosis. So make sure and always assume that every patient who is reaching you is having a cervical spine motion. That is the reason why don't restrict the word A for just airway. Please understand that it is airway maintenance with the cervical spine motion restriction. Okay. Then comes B. Don't restrict the word B for just breathing. Make sure breathing and ventilation. Okay. So the word B is breathing and ventilation. Okay. Third is C. C is not just circulation. Okay. Whenever we are handling such patients, the moment you secure 2 IV line, okay, you may feel happy. Wow, we have secured 2 lines. But despite your every effort of securing 2 lines, this patient may die still after a couple of hours. Okay. Why? Because with all this IV line, you may give replacement. You can replace the blood with a fluid or blood with a blood or whatsoever. Okay. But without controlling the hemorrhage site, there may be an underlying hemoperitoneum or a pneumoperitoneum, or sorry, hemoperitoneum or a hemothorax, or there is a bleeding into the musculoskeletal compartment, as in case of a femur fracture or pelvis fracture. So with an impending bleeding running inside the body, and you are just correcting the circulation by giving replacement fluids and blood, I don't think you can save the patient with only circulatory support. Rather, remember, C is not just circulation, but circulation with the hemorrhage control. So A for airway maintenance with cervical spine motion. B for breathing and ventilation. C for circulation and hemorrhagic control. So what is D? D is disability. D is disability assessment. For example, assessing the pupils, and very importantly, GCS, Glasgow Coma Scale. So see, whenever you learned Glasgow Coma Scale by heart or jotted down from this class or whatever class, you reach the ER, many times people will start his history itself with GCS. Okay, please don't do so. Okay, it is always airway with cervical motion restriction is the first preference, then breathing, then circulation, then you can worry about GCS. So remember, GCS comes under D, okay, which is disability assessment, including the neurological status assessment, Then comes E, which is exposure and environmental factors, Okay, so the order is like this. Please don't forget A for airway, and not only airway but a cervical spine motion. So now let's get into the airway. See, whenever there is an airway which is a compromised airway is there, first you should be in a position to recognize that there is an airway obstruction. How? Here comes a patient to you, and he is a 28-year-old male whatsoever, and this patient is in front of you. You try to talk with the patient, tap him and ask him, hello, what's your name? If he responds clearly with the words like clear words and a comprehensible words, which means his airway and breathing is normal, possibly high chance of being normal. Okay, so you are asking, what's your name? He is telling, yeah, myself, Dr. Kadir. I sustained a road traffic accident some half an hour back. So if he is communicating this freely, this comfortably, this clearly, then airway and breathing is usually normal. But rather, if he is having a labored voice, something like that, then you can think there may be a possible foreign body obstruction. There is something wrong with an airway. So you must have an idea, or you should have an objective signs. You should be in a position to recognize the objective signs in order to diagnose an airway obstruction. So what are all the objective signs? Remember, if the patient is agitated, that may indicate hypoxia. Okay, if the patient is agitated, it may indicate hypoxia. If the patient is obtunded, which means like a log, he is not responding, he is behaving something like that, it may be because of hypercarbia. The patient is cyanosed, again it is a feature indicating hypoxia. So all these signs you should be able to pick up that there is an airway compromise, possible airway compromise may be there. So if the patient is obtunded or cyanosed, and also look for, just a minute, there is a chat. Intros, please, you have missed. There is nothing great to give an introduction. Myself, Dr. Kadir, and I'm working as a orthopedic surgeon in Kaveri Hospital. And with related to the intro of this presentation, remember trauma. Abu will be giving speech before questionnaire. Okay, shall I proceed? The organizers, please say yes or no. Thereby, I will proceed from this slide. Okay. So, with related to airway, whether he or she is agitated, obtunded, or cyanosed, that is very important. That sign you should be in a position to pick up, that there is all these indicate that there may be a possible airway obstruction. And listen for any abnormal sounds. The person may be gurgling, the person may be having hoarseness, the person may be having a stridor. All these sounds, any abnormal sounds will indicate, may indicate an airway obstruction. So listen for an abnormal sounds. Okay. And next is evaluate the patient's behavior. Why this is very important? See, sometimes patient may behave entirely in a very disoriented way. And if it is disorientation, in reality, most of the time when you are in casualty, when the patient is behaving hyper agitated or disoriented, immediately you will match this sign with some intoxication. The patient is an alcohol intoxicated, something like that. So you will usually attribute all these signs and symptoms with related to the agitation and abnormal patient behavior to alcohol consumption, but never assume it that way. Okay, it may be a feature of hypoxia. It may be a feature of hypoxia until otherwise proven. Okay, don't attribute any of your clinical finding just to alcohol. Okay, you have to prove it in order to say. Okay, otherwise assume life-threatening complication as a reason for all the signs and symptoms rather than attributing it to simple other causes. Okay, that way you will not miss this patient's a vital compromise like airway. Okay, next thing is, so now you, by overview itself, you know whether this patient is agitated or tender, and you have to listen. And the next important thing, that you should know is if this patient is a trauma patient, a mere injury into the nose or the injuries around the oral region, injuries into the chest, injuries into the neck, injuries into the larynx, all these injuries itself may indicate there may be a threatened airway. See, for example, if there is a laryngeal fracture, okay, and there is a stridor, it indicates there is a threatened airway. And there is a multiple lacerations or the face being crushed, possibility of having an airway compromise is very, very high. So general behavior of the patient and the abnormal sounds. The third is injuries into the airway, injuries around the region of airway can tell you that there is a possibility of airway obstruction. Now, why I have put this slide? This slide is quite important in few sense. Point number one. See, whenever there is a patient who you are treating, and this patient may have you can easily secure an airway, or sometimes may have a difficult airway to be secured. So how to assess whether this patient will have a difficult airway or not? So the mnemonic they follow is lemon. The mnemonic they follow is lemon. Okay, so L for you look for any injuries around. You look for any injuries. See, there may be a laceration into the lip. There may be a broken tooth. All those things you look. Thereby, a broken tooth may cause an obstruction somewhere. Okay, so you look whether there is a possible, there is a difficult airway possibility. Next is you evaluate. What you evaluate? What you evaluate? See, if a person's if a person mouth, open mouth, can accommodate 3 finger of yours like this, 3 fingers. Okay, the rule is 3-3-2. If it accommodates 3 finger, first 3 is okay. If there is at least a 3 finger distance from the chin to the hyoid bone, okay, so that is the second 3, fine. The third is from the base of the mouth to the Adam's apple. If it accommodates 2 finger comfortably, then that is 2. So 3-3-2 indicates 3 fingers in between 2 incisor. Okay. Now another 3 is the distance between the chin and the hyoid can compromise, can easily accommodate 3 fingers. And the next 2 is the distance between the base of the mouth to your Adam apple should accommodate at least 2 fingers. So that is what 3-3-2. If all is there, then it is not going to be that difficult airway. Okay. The next is yum. What is yum? Mallampatti. What is Mallampatti? I have drawn here. Okay. So what is Mallampatti? See, this is an airway. This is an airway in which you can see the hard palate, the soft palate, and the uvula, and also the facial pillars and the posterior pharyngeal wall. Everything is clearly visible. This airway is not going to be a difficult airway at all. This airway is not going to be a difficult airway at all. While if you see here, in this, there is going to, the hard palate is visible, soft palate is still visible completely, but okay, even uvula is near completely visible, but the facial pillar and pharyngeal wall is not that completely visible. Okay, so there is a slight compromise. And in this, you can see only a soft palate and hard palate, and nothing else is visible completely. Okay, while in this, all you can see is only hard palate. All you can see is only hard palate, and there is no soft palate even is visible. So this is what Mallampatti grading. Okay, so in this, the last one is going to be a difficult airway, that it is going to be really difficult for you to put a tube in it. Okay, so that is Malampatti grading. Okay, and O is observe. Observe. Observe for other injuries, observe for contusions, observe for laryngeal fractures, observe for abnormal sound. Okay, all those things you should observe. And obesity. Okay, also obesity. Okay, all these things you should know. Okay, so that is O, and N is neurological status. Neurological status, neck mobility. Neck mobility. Okay, so this lemon is quite needed, quite important, that you should assess. And if there is going to be, with your lemon assessment, if you feel that this is going to be a difficult airway, you should inform a concerned person, which means a technical expert in the field of airway intubation should be called. Anyone cannot do such a difficult airway. Okay, so you call an anesthetist or you call an expertise people who can able to do or handle such evaluation. Why? When you evaluate it quite early, you can organize it. Okay, this patient is on the road and you assess the airway is going to be a difficult airway. Then while informing your primary consultant itself, you can say, sir, there is a possibility of a difficult airway. Make sure that adequate manpower and material and the expertise is available to handle such patient. All these things can be prepared. Why? Because we can do all this within that 1 hour golden period. So after this patient reaches the hospital, then only if you evaluate, then you have to call an anesthetist. The anesthetist will take another half an hour to arrive. It poses a huge threat to the life of the patient. Okay. Next. So what are all the airway management that you can think of? The airway management that you should think of is, first thing what I have explained in this picture is jaw thrust and chin lift. Look, what this person doing is what called as chin lift, and what this person is pushing is what called as jaw thrust. So jaw thrust and chin lift is one basic thing that you will do in any airway compromise to begin with. And the moment you open the mouth and look for any abnormal object, any foreign body, any broken tooth which is obstructing the upper respiratory tract itself, which means the oral cavity, then try to scoop it out, make sure that whether he is having cleared airway or not. If otherwise, you can go for what is called as an oral tube or a nasal tube. Okay, but remember, with related to nasal tube, one thing is very important. If you are planning to put a nasal tube, what in the picture we have shown is a oral tube. If at all you are planning to put a nasal tube, hope you can identify, you know how to identify the size. The size of the nasal tube should match with the size of the external orifice of the nose, or otherwise the diameter of your little finger. Okay, that's how you will choose the size of the nasal tube. If at all you are planning to put a nasal tube, remember you should rule out cribriform plate fracture. The patient is having an anterior cranial fossa cranial base fracture, and if the cribriform fossa is opened out, if you put a nasal tube, rather than intubating your respiratory tract, you will intubate your brain. Okay, so please one of the absolute contraindication for putting a nasal tube is head injury, in whom you are suspecting a cribriform plate fracture. So please don't do that. And oral tube. Okay, oral tube, you always put it like this. Okay, you always put in this inverted C, and then once it reaches back, then you can rotate it. Okay, so that's how you will insert an oral tube. Remember, both this procedure will cause severe gagging. Okay, and in a neurologically stable patient. And if a patient can comfortably, if the patient can withstand it, it means his neurological ability is good. His neurological ability is good, and his need of airway is less. Okay, So it requires a lot of gagging reflexes. It requires a lot of gagging reflexes, and any conscious patient will resist this. Any conscious patient will resist this. Coming on to the next thing, what is called as the laryngeal mask. Laryngeal mask. So what is laryngeal mask? This is a laryngeal mask in which it is again a cuffed tube, but the cuff is having it's a pear shaped cuff there will be, and if it is inflated, if it will go and seal the GI tract and make an opening only for the respiratory tract. Okay, thereby secures the airway. This is what called as a laryngeal mask. Okay, but remember, in all these three, whatever you do, the jaw thrust or chin lift or oral tube or nasal tube or laryngeal mask, despite laryngeal mask is having a cuffed tube, that cuff is not reaching a place anywhere below the vocal cord. Remember what you mean by definitive airway. The word definitive airway means a position or placement of a cuffed tube below the level of vocal cord is what called as a definitive airway. So in that case, the definitive airway is ET tube. Okay, in that case, ET tube and cricothyroid tube or tracheostomy tube. Okay, so when you are inserting a cricothyroid tube or an ET tube, and all those things are the one which you can call it as a definitive airway. Don't tell a laryngeal mask as a definitive airway. Laryngeal mask is not a definitive airway. Laryngeal mask is not a definitive airway. And there is another thing what I have shown here, which is called as needle cricothyroidostomy. Okay, here we are just inserting the needle between the thyroid and the cricoid. Okay, these are all emergency procedure you can do. Though you open the thyroid and cricothyroid membrane and you inserted a needle in it, it doesn't mean that you have inserted a cuffed tube. So a needle cricothyroidotomy should never be considered as a definitive airway. Okay. So through all this, you are going to rescue the airway. Okay, that you are going to rescue the airway. Remember, if the neurological status is less than, or if your GCS is less than 8, the patient may have a stable airway. Despite in your D assessment, if you find the patient's GCS is less than 8, then ET tube, you better put it, because this patient is in unconscious state, that this person is having an impending airway compromise. Better apply an ET tube now itself. Okay, so defective neurological, or the neurologically this patient is unstable and this patient GCS is less than 8, it is considering the situation as an impending airway compromise. Even this patient at present may have a sound airway, but still with a poor GCS, him entering into a impending airway compromise is very, very high. So please put an ET tube. Now, getting into what is called as breathing. Many people used to confuse the word airway and breathing because both mimic same. The actual truth is not so. See, a person may taken air from the external to his body up till the lung, fine. Everything may be fine up till then. But from there must be a perfusion of air from his airway to his blood. Anything which prevents this at the level of lung or at that is what called as a breathing difficulty. For example, consider there is a huge pneumothorax or there is a huge hemothorax. In both the case, one lung is completely being pushed to the other side, and it is the lung size is shrunken so much it cannot deliver whatever the air that it took to the body actually. Okay, so airway is fine, but the breathing is not fine. Okay, so conditions like hemothorax, pneumothorax, tension pneumothorax, simple pneumothorax, open pneumothorax, all these things will cause a breathing compromise. Now, what you should know is the type of pneumothorax. See, this is what called as a tension pneumothorax. While this is what called as an open pneumothorax. Tension pneumothorax and open pneumothorax. Remember, tension pneumothorax is actually happening something because of a valve-like mechanism. What is valve-like mechanism? The person is respiring and the air is getting into the lung, and because of an injury to the lung, that lung air is getting into the pleural cavity, but this air is not getting back into the lung for expiration. So there is a single valve mechanism. So air keep on accumulates into the pleural cavity, but doesn't get out. So this accumulation keep on building up and thereby completely crushing the lung to one side. So that is what called as a tension pneumothorax, simply because the mechanism is a valve mechanism. And what is open pneumothorax? Open pneumothorax is there is a lung injury and air is leaking into the pleural cavity because of the lung injury, and also there is an injury to the external. Okay, so air is, whenever this patient is trying to inspire, the air from the lung is entering the pleural cavity, and also the air will enter the pleural cavity, not only from the lung but also from the external. Okay, in open pneumothorax, what you should understand is this air, if there is a tension, severe tension builds up, this air can also come out through the same open injury. Yes or no? But what will happen, especially when you are a junior resident? See, most of the candidates, you people are doing your MBBS. Okay, in that case, when open injury to the chest comes, and there may be a pneumothorax, but the moment you see this injury, what you will do is, there is an injury, all I need to do is a suture. Okay, and especially when you are in CRRA, your mind will always think about suture chance, and you will go and try to suture this wound. If you go and suture this wound, what will happen? You will convert an open injury or an open pneumothorax into a tension pneumothorax. Okay, so please don't close such an open pneumothorax defect with suturing or a complete packed dressing. Rather, what you should use is dressing of this way, okay, in which you will seal 3 ends and leave one end open. Why? Because this will act like a valve. So whenever this person now try to inspire, the defect is sealed completely. So from the external, no air will get in. But when there is a tension building up inside the pleural cavity, that air can come out comfortably. Okay, so so you create an artificial valve with your dressing material outside, and never ever try to completely seal an open pneumothorax. By doing so, you will convert an open pneumothorax into a tension pneumothorax. Similarly, let me say another important thing, that the moment you intubated the patient, securing his airway, and this patient is having a simple pneumothorax, and you intubated the patient, instead of giving just a bag and mask ventilation and assessing, and before ruling out the pneumothorax, don't just go and connect it into a high flow ventilator. So if you are comparing it, if you connected the patient to the ventilator, and if the pressure is going to be high, in that case, you will convert a simple pneumothorax into a tension pneumothorax again. So make sure that before connecting the airway, whatever you have fixed, and after your bag and mask, okay, without ruling out a pneumothorax, don't just go and connect it into the ventilator. If at all you are connecting to the ventilator, before connecting to that ventilator, you must have put a chest tube. Look, what is chest tube? Yeah. Okay, you should insert a chest tube release all the pleural pressure, be it in the form of if there is a pleural pressure because of the pneumothorax, you should remove the air. If there is because of a massive hemothorax, then blood, whatsoever it is, you should remove that collection into the pleural cavity before connecting this patient into the ventilator. Okay, so insert the IC tube. Okay, so what are all the points that you have learned is, whenever there is an open pneumothorax, please don't suture. By suturing it, you will convert an open pneumothorax into a tension pneumothorax. Whenever there is a simple pneumothorax, before ruling it out, don't just go and connect it into the ventilator. Make sure, if at all you are connecting to the ventilator, before that you have applied an ICT. Thereby, the pneumothorax is released. Okay, so that is very important. And in case of an open pneumothorax management, the dressing packing should be like this. Thereby, you create a dressing like a valve outside. Okay. And what is called this? What is this? This is what called as a massive hemothorax. Massive hemothorax. In massive hemothorax, what you need to know is how much amount of blood should be there in the pleural cavity to call it as a massive hemothorax. It should be at least at 1500 ml, at least 1500 ml. Okay. So to call it as a massive hemothorax, or with related to the patient's complete blood volume, if it is at least 1/3 or of the blood is accumulated, more than 1/3 of the blood is accumulated, then you should call it as a massive pneumothorax. Massive pneumothorax. Sorry, hemothorax. Massive hemothorax. So now, the next thing that you can see is, here is the ICD tube. Here is the ICD tube. So ICD tube, how it is inserted? See, the location is very, very important. That it can be in the 5th intercostal space, which corresponds to the level of the nipple, and the area between the anterior and the mid-axillary line. The space between the anterior and mid-axillary line, in the 5th intercostal space, is an ideal space. Okay. With related to the tension pneumothorax, many people they will put a needle. Okay. In trauma management, you can see. So where they will put, usually they will put it in the 2nd intercostal space. In the 2nd intercostal space. In the mid-clavicular line. In the mid-clavicular line, the 2nd intercostal space they used to put. But remember, if the patient is very obese, okay, if the patient is very obese, whatever the needle that you are putting may not even cross his subcutaneous, may not space. In that case, it is again the safer place to release the tension pneumothorax is also the same 4th or 5th intercostal space is again a safer position between the mid-axillary line and the anterior axillary line. The space of intercostal, 4th and 5th intercostal space is again a safer position if you feel that the 2nd intercostal space, if the person is obese. So as according to ATLS 10th edition, they suggest only in the child you prefer to go for the 2nd intercostal space. Otherwise, you prefer the 4th or 5th intercostal space. Release the tension by putting the needle into it. Okay, so the location is going to be similar to that of the intercostal tube. Okay. Now, see, X-ray is never ever done in a primary survey before securing the airway, breathing and circulation. Okay, it is airway, breathing and circulation which is more vital than your X-rays. Now what I am telling is, why I have displayed this X-ray is, as primary survey includes X-ray, vitals X-ray has to be taken, but more than X-ray, what are important? Airway, breathing and circulation is important. Okay, now just assume this person is, after you securing the airway, breathing, is having a fracture like this. Okay, like this person is having a fracture here. Okay, look, there is a huge pelvic diastasis. Okay, huge pelvic diastasis, and there is a femur fracture. Okay, if that is the case, this person can have a compromised circulation. This person may have what is called as a compromised circulation. So what will happen? Remember, the two potential cause of death are exsanguination and head injury, I told. And most of the time, head injury, if it is severe enough, most of the patient will die in the first week itself, that you cannot do anything. Okay. But related to the second is circulatory collapse is very, very important and very vital. that you should know. So what now you are going to see is the hemorrhage, exsanguination, and hemorrhagic shock. So what are all the various classes of hemorrhagic shock? The hemorrhage, the blood loss, if there is class 1, class 2, class 3, class 4, which means class 1, mild shock, moderate shock, and severe shock. Class 1 is if the blood loss is only less than 15%, which means you will not find any much of clinical abnormality. The heart rate will not be altered much. The blood pressure will not be altered much. Pulse pressure will not be respiratory. Nothing will be altered. Nothing will be altered much. So you may not require any blood transfusion. Also, if the loss is going to be less than 15%, okay, that is class 1 shock. What is class 2 shock? If the loss is going to be 15 to 30%, 15 to 30%, then it is a class 2 shock or a mild shock, in which the early parameter that you can see is a heart rate is altered. Heart rate is altered. That is class 2. Rest of the thing will remain almost normal except for the pulse pressure. With related to class 3 or a moderate shock, the loss of blood is 30% to 40%, in which it is not only the heart rate, but the BP will slightly start dipping, and the respiratory starts picking up and the urine output start reducing. If the same urine output is massively reduced, if the BP is massively reduced, if the heart rate is very high, elevated much, then you should think about a severe shock in which there is a more than 40% of blood loss, Okay, so that is all a feature of a class 4 shock. Okay, and remember, in class 1 there is no need for blood. In class 2 there is maybe a possible need for blood. Class 3, of course, there is a need for blood. Class 4, you may require even a massive transfusion. Hope massive transfusion, you know, possibly the complications of massive transfusion, and the possibility of hyperkalemia, the possibility of hypocalcemia, and all such electrolyte imbalances has to be borne and thought in mind before you initiate a massive transfusion. You should have all metabolic supports. But remember, you may evaluate the shock, but in circulation, the most vital, the first step to start is secure the IV line. The first step in circulation management is secure an IV line. So how many IV line? You should secure at least 2 IV line. At least 2 IV line is mandatory. Okay, at least 2 IV line. Okay, and what bore? At least green Venflon. What does the green color indicates? It is an 18 gauge needle. If you want to know what are all the gauge for what Venflon, remember this is an 18 gauge needle, this is a 20 gauge needle, and this is 22, and this is 24, while gray is 16 and orange is 14. Okay, why we are going for 18 gauge needle? Because anything less than that, 18, 14, 16, 18, everything is a large bore. And hope when your first year physiology, there is some law that you would have studied even right from your schoolings, 11th and 12th standard also. You learned a law called as a Poiseuille's law. What is Poiseuille's law? More the diameter, okay, fourth power of the radius, okay, the flow of fluid through a tube is proportional to the fourth power of the radius, which means more is the radius, more is the flow. So large bore cannula has to be inserted. So at least 18 gauge cannula, at least 2 IV line has to be inserted. And now your next question, okay, we have inserted, sir. By chance, if we are not getting an IV line, what else we can secure? If you are not getting an IV line, try to get an expertise opinion meanwhile, and to start with a central line. But in an emergency, when you don't have such expertise, when think that such expertise to arrive, if it takes time, remember you can secure another safer line, what is called as an interosseous line in a proximal tibia, So through the bone itself, you can put a needle. Okay, you can use a bone biopsy needle or Jamsheti needle and put it into the bone, and through interosseous you can supply your IV fluids. Okay, so what fluids you will use? Remember, while putting the Venflon itself, you can gather blood and send the blood for basic investigations, and also make sure you are going to handle a patient with shock, that the blood sample is also sent to the blood bank in order to arrange blood for the patient, or in order to assess the blood group and typing. Okay, so make sure, don't just put line and then start an IV fluid, and after some time don't draw blood from another vein. Okay, have sequence in your mind that you should be, whenever you are putting line itself, you should draw some blood for the basic investigation and also for the blood grouping, matching and typing. Now, what is the fluid that you can start? Any isotonic fluid. ATLS doesn't say only this or that. Okay, they say isotonic fluid is fine. Crystalloids, be it ringer lactate or normal saline, is fine. Ringer lactate, if available, is better. Okay, any isotonic fluid is fine if you are to begin with. Don't give 5% dextrose, sorry, 25% dextrose, 20 dextrose. Remember, the moment you are giving the 20 dextrose, while giving that fluid may be an isotonic, but the moment it reaches the blood, because of the blood insulin, this glucose is going to be completely removed. So what will happen? This fluid, which is now inside the body, will convert itself from isotonicity to a hypotonicity. So whenever there is a hypotonicity, this fluid will try to go from the intravascular compartment into the extravascular compartment. Okay, extravascular, which means into the cell. Okay, so what will happen? Intravascular volume will reduce. Okay, and there is going to be a possibility of cerebral edema possibility is high. That's why they say don't give a crystalloid fluids is allowed, but don't give like a 20 D, because the moment you give in, it will convert itself into a hypotonic fluid. So please don't give. Okay, then whenever you are organizing or arranging blood, in what proportion you will give? For example, when you are asking for blood, the blood will be packed cell volume is to fresh frozen plasma is to platelets. I have seen in most of the setups, in most of the primary centers, they used to give like a 3 blood or 3 packed cell for 1 fresh frozen and 1 platelet. Okay, but remember, all these ratios are wrong. For every packed cell in trauma management, for every packed cell that you give 1 fresh frozen plasma and 1 platelet. So 1:1:1 is the ideal composition in which you should give. 1:1:1 is the ideal composition you should give. And then coming on to the next picture. Look, this is how this limb is looking deformed, and there you should think of a femoral fracture. Why I am telling this? Have you during the initial part itself, I said C is not just to achieve good circulation by getting a IV line, it is also hemorrhagic control. Okay, whenever there is a femur fracture, the average blood loss is into the compartment is 1.5 liters. Okay, 1 to 1.5 liter is average blood loss. If there is a pelvis fracture, average blood loss is 1.5 to 2 liters. So when such fractures are there and you didn't even splint the fracture, whatever the circulation whatever the circulation fluid or the replacement fluid you give, the moment you started mobilizing and the fractures start mobilizing, the bleeding is going to be again enormous, and you cannot prevent a collapse. In that case, it is better to splint it. So how you can achieve the hemorrhage control? You can achieve a hemorrhage control, especially if it is a fracture. You can achieve it by splinting, or if there is a ooze which is coming out and you are trying to pack it. If you are trying to pack the wound, don't just remove your hand often to see whether on packing it is stopped or not. Don't try to explore with an artery to catch hold of the vessel. Don't do all that. Just try to pack it and apply what is called as tourniquet. tourniquet. Okay, tourniquet. So you can apply tourniquet. So splinting, tourniquet, packing. Okay, all these things you should know in order to control whenever there is a fracture. Whenever there is a fracture, and if there is an open bleeding happening, if there is an open bleeding and the blood loss is massive, then you may tourniquet will be of great help. Tourniquet will be of great help to you. Then, so now we managed airway, breathing, circulation. I'm not getting into the disability and Glasgow Coma Scale management. Now, after managing everything in the primary survey, now your patient is stable. Then in secondary only, you should ask about history. Okay. So whenever the patient comes to you in trauma, don't give much of importance to the entire history in the primary survey. In primary survey and the primary management is always about airway, breathing, circulation, stabilize the patient. Okay. Then in secondary only, you should, secondary survey only, you should have a huge good amount of history, in which the mnemonic that you should remember is ample history in secondary survey. What ample history? A for allergy. M for what are all the current medication the patient is using. P for past illness and pregnancy. L for last meal, because this patient may be now rushing into the theater for some procedure. To inform your anesthetist. Okay, so last meal. And E for event and environment related to the injury. Okay, so all these history you can take only in the secondary. So this is the only part, I think, in the entire medicine where someone is suggesting you more than the history, start managing the patient first and then you take the history. Okay, in trauma, whenever there is an acute trauma, this is better. You start managing the patient first and then you can take the elaborate history later. Okay. Coming on to adjuncts. Adjuncts are the one. Now you know the primary survey is related to airway, breathing, circulation, disability, and environment exposure. While doing the primary survey itself, there are certain primary adjuncts you can use which will help you in managing. For example, pulse oximeter will help you to assess the breathing. ECG, continuous ECG monitoring. Carbon dioxide, BP, urinary catheter. When you are managing shock and all, urine output plays a vital role. Clinically, the parameter which can help you to assess the adequacy of resuscitation in clinically is urine output. So urinary catheterization, gastric catheterization, your ECG, CO2 monitoring, pulse oximeter, all these things are vital primary adjuncts and needed x-rays, like fracture in the femur. And if you have applied a tube to the to an airway, then in order to confirm the position, so needed x-rays you can take in a primary as a primary adjuncts. Other x-rays, CTs, all these things will come as a secondary adjunct. In primary adjunct, one important thing that you should know is fast scan. Okay, fast scan, advanced focal assessment sonology is fast scan. Okay, in which you are going to assess various quadrant of abdomens. Okay, and diagnostic peritoneal lavage. Okay, diagnostic peritoneal lavage. So all these things will come into as a primary adjunct supply. Primary adjuncts. Now, in the primary itself, the two things that we don't give much of importance is, see, most of the time road traffic accident, if it happens to the two-wheelers, and they will be having helmet on them, and if there is a cervical injury, and if you don't know how to remove a helmet, almost you literally caused death. You are the one who literally caused the death of the patient or lifelong disability. In that case, remember to remove the helmet, at least two people is required. During the secondary survey, when you are going to assess the spine, putting this patient away from the spine board, okay, in that case, whenever you are shifting the patient or while transferring whatsoever, you should use a protocol called as log rolling, and it requires at least 4 people is required to do the log rolling. Okay, now one person should stabilize the spine and another person should stabilize the torso and the hip, another person the hip and the limb. All this has to be stabilized accordingly, and one person to assess. Okay, so at least 4 people is required as per ATLS. Now, coming on to a trauma, a patient is coming to you like this. What will you do? So this injury is massive. It is severely crushing in nature. And you can say that this is a type 3C open fracture. So what are all the, how will you assess an open fracture? If there is an wound less than 1 centimeter, that is type 1. If the wound is 1 to 10 centimeter, that is type 2. There is a fracture, but in which the wound, external wound is less than 1 centimeter, it is type 1 open fracture. If it is 1 to 10 centimeter, it is type 2 open fracture. If it is more than 10 centimeter or gunshot injury or gross contamination injury or warfare injury, or it may be farmyard injury, all these things will come into type 3. And remember, a type 3 can be called a simple type 3A, or it can be slightly more than that, B or C. Here, in this condition, all the vessels, everything is crushed. So whenever there is a vascular damage, that will become type C. Whenever there is a massive skin loss, and you require a cover, plastic cover is required, that is type B. So type 3 is further classified into A, B, C, in which A is the one where there is an extensive injury, but the skin is adequate. Okay, so you can assess the adequacy of skin. You can cover the injury with the skin. Okay, it is possible for you to close the injury. Okay, so there is no requirement of any plastic surgeon. That is type 3A. There is a massive skin loss and you require a plastic surgeon, severe periosteal stripping, and there is a massive skin loss that you require a plastic surgeon to manage. So that is a 3B. And what is type 3C? It is not only a skin loss, but also there is a vascular damage. That is 3C. So in 3C, remember, there is not only an orthopedician is going to play a role. Who else? A plastic surgeon and also a vascular surgeon is going to have a role in a type 3C. Okay. Now let's get into what is called as damage control orthopedics. Damage control orthopedics. What is damage control? Not only damage control orthopedics, let us focus it as a damage control surgery. Now the patient, a 22-year-old male, has reached you with fracture of bilateral femur, in which one femur is open, and pelvis injury, and this patient is having an abdominal contusion and the abdomen circumference is keep on increasing in size. What will you do? Don't say that there is a bilateral femur, so I will go and put one nail in one femur, another nail in another femur, and then I will try to fix the pelvis fracture. See, trauma itself is a massive stress to the metabolism. Okay. And surgery is another massive stress that you are going to pose on the patient. So what does damage control orthopedics says? Whenever a patient who is coming to you as a polytrauma, and there is multiple fracture in case, do all mandatory vital surgeries with least damage to the metabolism. For example, if you try to open the fracture, reduce the fracture and put a nail, there is going to be a massive blood loss. And if there is 3 or 4 fractures, all you are going to fix in a same day, the anesthesia time, the prolonged surgery, and the medication this patient is going to ensue because of your surgery and the supplements, and think of all this patient will die in 2 or 3 days after your massive heroic procedure. So do what is vital. To put an external fixator, hardly it is not going to cross any time more than 40 minutes to fix 3 or 4 bones. In that case, fix all the polytrauma with an X fix and come out. Give the patient to the surgeon to pack the abdomen because of the expanding circumference, and you are suspecting some bleed inside. Okay, there is a pelvis fracture also. So in order to pack the abdomen, you as an orthopedician go do the external fixator and give the patient comfortably to a surgeon within 20 or 30 minutes. Thereby he will start packing the abdomen and get the patient back in 1.5 hours. Okay, now stabilize the patient, correct his metabolic issues, make him fine for some days, and after that you take him to the theater again for the definitive surgery of fixing every individual bone one by one. So first correct vital injury by least damaging surgery. Okay, least damaging surgery. Correct only vital injuries. Okay, then put the patient back into ICU and make him stabilize. Once patient is fit for the procedure, then you can take a definitive surgery. So this is what called as a damage control surgery, in which remember in orthopedics, external fixator plays a very good role. External fixator plays a very good role while managing a damage control surgeries. So this is how an external fixator will look like. Okay, see, Ilizoro is not possible in a trauma setup, but you can very comfortably apply this type of external fixator or this type of external fixator and come out. Okay, give your patient comfortably to the surgeon to operate and then come out. In this injury, you may require a vascular. See, all this injury will definitely go for amputation. But otherwise, if the vascularity is intact and if the skin cover is slightly better, in that case, there will be a vascular repair. So vascular injury. So first try to save the patient life. Next, you can try to save the patient limb. Okay. With the injury like this much crushed, all the muscles are completely crushed. And remember, you should think of what is called as crush syndrome. These muscles will release myoglobin, and these muscles are rich with hyper potassium. So these patients will have hyperkalemia, lactic acidosis, and myoglobin will cause a renal tubular damage. Renal tubular necrosis will ensue. So all these metabolic deformities also should run behind the back of your mind when you are assessing this much injured patient. So first, save the life. Okay, then you can think about saving the limb. Even without this much massive crush externally, there can sometimes be a crush into a specific musculoskeletal compartment, but the skin is closed. In that case, what it will ensue is called as compartment syndrome, very common in leg. Okay, very common in leg and forearm. In forearm, compartment syndrome very common in pediatric population following a supracondylar fracture. But otherwise, in a road traffic accident, leg is the most commonly affected compartment. And in leg, the anterior compartment is most commonly affected. Same in the forearm also, again, anterior compartment is most commonly affected. In the forearm, the most common nerve to be affected is median nerve. And in the anterior compartment, the most common nerve to be affected is deep peroneal nerve. And with related to compartment syndrome, remember, the person may not show a massive crush-like feature as I shown in the previous pictures. Rather, the patient will complain of pain. Okay, the features of compartment syndrome is pain, pallor, chillness, poikilothermia, pulselessness, paresthesia, okay, paralysis. The person may not move the limb. The person may have an altered sensation. Patient pulse may not be felt. Poikilothermia, pallor, pain. Most of the time, when you are thinking of compartment syndrome, everyone will ask, what is the pulse? Is pulse present? Is pulse present? Pulse present. Remember, pulselessness is not an early feature. It is a late feature. It is the least reliable. Don't rely on pulselessness. Least reliable. Don't rely on pulselessness. Rather, the most important thing that you should rely is pain, pain, pain. That pain which is out of proportion to fracture and not relieved with analgesics, okay, that indicates is compartment syndrome. So please remember, whenever the person is having a pain out of proportion to the fracture and not relieved with any of your analgesics, okay, and that pain is aggravated with passive stretching of the affected muscle, that is what classical for compartment syndrome. And please remember, pulselessness is a least reliable feature. It is the least reliable feature. Okay. So what are all the, so in this session, what we have studied is airway, breathing, circulation is most vital in that order, that airway has to be corrected before breathing and circulation. And with related to limb, the limb crush injury and open fractures are an emergency, and compartment syndrome is an emergency, crush syndrome is an emergency, and vascular injury is an emergency. And in compartment syndrome, if it happens, you should do fasciotomy. And in open injury, with related to this open injury or polytrauma, we should always go first for damage control orthopedics. Why? Because, see, why not a direct internal fixator in an open injury? Because of severe infection associated with this injury. If such injuries has happened, do you think what will be the infection rate? It will be very massive. Okay, so don't think of doing any internal fixation in open injuries until unless it is a type 1 or type 2, where you can be. Should I listen anything, Abu? Hello? Am I audible?
Yes, sir, you're audible, sir.
Okay. So whenever there is an open injury, the possibility of infection is very high. And if it is going to be type 1 and type 2, okay, you can give good wash debridement and then proceed with an internal fixation. But if it is a type 3 injury, don't think of any internal fixation. Always proceed with an external fixation. And also in polytrauma, don't try to do any heroic procedures. Okay, always try to do minimal damage causing surgery with the maximum output, with the maximum benefit that you can reap, with a less time consuming. All those things should be running inside your mind rather than doing any heroic procedure. Let the patient stabilize comfortably in the ICU. Later we can put the patient into a definitive procedures. And how an external fixator will look, that's how it is going to look. And what will you do in case of a compartment syndrome? In case of compartment syndrome, you will do what is called as fasciotomy. Remember, fasciotomy is going to be like this, and it will yield a very ugly scar. But whenever you are in doubt of compartment syndrome and you are assessing it with a catheter, after assessment with a catheter, if you feel that compartment syndrome is there, please go ahead with the fasciotomy and don't show any mercy, because this compartment, if it is not released, all the muscle is going to go for necrosis, and there is a possibility of renal tubular damage, and even life can be compromised. So what is more important is life, and then you can save the limb, and then only you can think about the cosmesis. Okay, so please never and never be hesitant to do a fasciotomy when you are in doubt of a compartment syndrome. Okay. So that is all what I got to say for you now in this 1.5 hours. If you got any doubts, you can ask me. Thank you.
So before we go on with the doubt session,
okay.
So I'd like to thank you. There's a golden hour between life and death. Management of the severely injured trauma patient is a complex and vital aspect of the trauma specialist. Proper management encompasses multiple specialties and is a job that requires collaboration with many providers and requires rapid management. On behalf of IIMS in Tamil Nadu, we appreciate and thank you for your efforts and insight presentation to enlighten us on trauma management.
Thank you.
Talk about Dr. Kathirazhagan sir's achievement and merits is a magnificent task, but to name a few, sir has more than 30 publications to his name and also has been awarded the best speaker and paper presenter in various conferences by him. Dr. Stalin is also accredited to various courses in trauma and life management and is also a coach for these privileged courses. And to also mention, Sir is an honorable member for national, state level and regional level learned societies. It was a very great honor to have you on board this workshop, sir. Participants can now post their questions. So the first question, so how are we supposed to control hemorrhage in case of a femur fracture when we are at the front?
See, in femur fracture, I just wanted to ask you whether it is an open femur fracture or a closed femur fracture. If it is going to be a closed femur fracture, you cannot control it just by giving pressure or anything because you are not seeing any open bleeding site. In that case, all you need to do is the trauma splint, as I have shown you in this picture. See, they have splinted it. Okay, so all what you can do is splinting the fracture with a splint like this will help you to prevent further hemorrhage. And you should have secured a line and you should have arranged blood. In case of an open fracture, if there is an open bleeding site you can see, then you can give pressure into the site of bleeding, and you can apply pressure onto the sites of bleeding, or you can use a tourniquet. Apply an X-fix once you get once the patient is surgically operable. Okay, that's how you can control it. Anything else?
Yes, sir. So how much period can we keep the patient in ventilation in case of a trauma?
See, that it depends, no? See, remember, what I see with most of the MBBS students is they are worried and trying to learn. See, learning ventilator is a task of even not even most of the postgraduates are worried. When you are in practice, you should worry about how to manage the patient with ventilators, etc. You are now in the front end. Okay, so your job is to call for a help in case of an emergency rather than trying to expertise in every single aspect you learn. Okay, so as a trauma surgeon, please have a realistic expectation. This patient will be in ventilator as long as this patient's breathing sets in. Okay, as long as I mean, as long as he is dependent on ventilator, he will be on ventilator. Unless the spontaneous ventilation ensures, we should put them on ventilator. Okay, don't worry much about ventilator and ventilator related things, because you are in the front end, and the moment this patient is going to be in the ventilator, this patient going to be into the ICU management. Okay, the ICU to expertise will manage. So as a frontline trauma, you should know whether this patient require a ventilation or not. Is this patient fit for a ventilator or not? That's all. So when a person is having a simple pneumothorax and you have put a ET tube, that alone is not a good criteria to keep this shift this patient into a ventilator. Rather, if the patient is having a pneumothorax, then you should put a tube before putting this patient into the ventilator. So a basic knowledge of that thing is more important rather than worrying about how long should this patient be on a ventilator. Of course, the patient will be on ventilator as long as he requires it until he gets a spontaneous breathing.
So any other question regarding? Yes, sir. There are so many questions. So there's one more question.
Okay.
Yeah, we'll filter and give you, sir. So okay. How has pandemic affected trauma management?
Massively, man. I can talk for hours and hours on this topic, but let me say, trauma management is altered. As such, the trauma rate is reduced. But remember, whenever there is a trauma, and all I said is the golden period is only 1 hour, I said. Okay. And in pandemic, most of the small scale and mid scale hospitals are closed. And most of the hospitals are unreachable because of the lack of logistics. Okay. In that case, most of, if at all any trauma happened, and if it is severe, the patient, the possibility and for the patient to reach the hospital is getting delayed a lot, thereby rescuing a severely injured patient in this pandemic is getting, the possibility is getting very meager. So that's the sad part. And the other thing is, most of the hospitals are not taking the patient. Most of the doctors, some of the time, are hesitant to expose themselves to the patient who are not tested with COVID. But the COVID test results are getting one day it is taking. So the emergency managements may go delayed, may go or slightly hampered. Rather, what I said is, you always try to follow the universal precaution. Assume every other trauma patient who are reaching you as COVID positive, and then just do the damage control procedures, quickly come out. Okay, thereby exposing yourself also less to the victim, and the victim also will not have much of metabolic derangement. You doing an extensive procedure. Okay, so what I'm trying to say is, try to do assume all your trauma patient as a COVID positive, and do just damage control procedure in emergency setting, and then shift the patient to ICU and assess all his COVID status and everything, and then you can do the definitive procedures later once you and the patient is convinced and confident.
Yes, sir. How to identify open and tension pneumothorax in field settings?
Open pneumothorax, I said, no, there will be an external injury and it is open. You should look for an open injury.
Okay, sir. We're going for the next question. Should chronic kidney disease be considered in elderly trauma patient during primary investigation?
See, when you are managing the patient in trauma, I said airway, breathing, circulation matters. And history of any other diseases, past illnesses, everything will come only in the secondary survey. Okay. So when you are sending the investigation, there is nothing wrong you sending urea, creatinine, and other thing. But that report, or waiting for that report, which hampers your primary survey and primary management, is a sin and crime that you are not following the protocol accordingly. So in that case, you can assess the patient for whatsoever you want with the blood sample that you have taken. But remember, you can assess the base deficit, and obviously base deficit has to be assessed in order to assess your adequacy of management also. But remember, the report should not be hampering your primary survey and your primary management.
Yes, sir. So how can we stabilize cervical spine injury if later it may lead on to neurological shock?
How can you manage a cervical spine injury? See, whenever you are the person who are exposed to the trauma setup or the trauma patient, always carry this cervical collar. Okay, whether this patient is having a cervical spine injury or not, you invariably apply Philadelphia collar. Okay, and once all your primary survey is over, once the patient is stabilized, then when you are taking the secondary survey, when you are going for screening of the spine, once you are ensured and assured that there is no cervical spine injury in this patient, then you can remove the collar. Otherwise, every patient, trauma patient reaches you, you should assume there is a cervical spine injury. By early mitigating the complication, you can avoid causing neurological damage to such patients. Then,
so how are eye injuries managed?
how are eye injuries are managed? See, remember, of course, it's a very good question. But right from the beginning, I'm telling, in trauma, see, you are asking this question to an orthopedician. But as a trauma surgeon, what I should give more importance? My initial importance is airway, breathing, circulation. With the moment I see an eye injury, okay, and there is a huge hematoma again in the patient's head, including the eye area. The more importance I will be giving, not to the eye, not to saving the eye, but the most important what I will give is the associated head injury. Whenever there is an eye injury, this patient possibility of having a head injury and anterior or middle cranial fossa fracture is very high. Okay, so in my practice or in my way, you should first try to save the life. Then with related to eye, you can manage. You can call an ophthalmologist and you can ask him if there is going to be a foreign body, you can remove it. And if there is going to be an optic nerve damage or anything like that, do you think rather shifting this patient to a hemoperitoneum or pneumoperitoneum management by a thoracic or abdominal team, will we be shifting this patient to ophthalmologist for handling the optic nerve? No. It is first life, so we will be first managing the life, and then we will ask the ophthalmologist and we will call the expertise to manage the disease accordingly. So with related to eye, it should prime you to concentrate more on its associated head injury rather than managing the prime eye injury as such. Okay.
Okay, sir. So how to restrict cervical mobility?
I said you can apply a Philadelphia collar, which is a hot collar, which will definitely restrict. When the patient is on spine board and applied a Philadelphia collar, it must restrict the spine mobility, number one. And when you are removing a helmet, obviously the spine movement is very common. In that case, it requires at least 2% for you to remove the helmet, 1% to stabilize the spine by keeping the along the axis of the neck, both his hands along the axis of the neck with his open index finger, and thumb to stabilize the jaw like this. So he will be stabilized like this. Okay, thereby the neck and the mandible is stabilized with the palm and the thumb. Okay, thereby the helmet can be comfortably removed by another person. Okay. The next possible damage for the spine will happen during a log rolling, in which one person exclusively should be given to stabilize the spine while the patient is being log rolled.
So we're going with the last question. So if we are a trauma doctor and we are having there's a road traffic accident, how to manage it without any equipment, sir?
Come again?
So we are not under duty. Just by going somewhere, we see some road traffic accident.
Okay.
Some trauma, but we are without any equipments. How to give first aid, sir?
Oh, that's a good question, and that's an enormous question also. See, remember, what we discussed today is advanced trauma life support. What the question you asked is basically not an advanced trauma life support. What you are going to give is only basic life support in that case. Okay, in that case, you should not be thinking about ET tube. You should not be thinking about the oral tube. You should not be thinking about nasal tube. No single equipments you got. Okay, all you got is only your bare hands and possibly some cloth, some other materials. Okay, in that case, if there is an open bleeding, you can just compress it with whatever the rags that you find, like a cloth. Any clean cloth will do. Okay, you can support the bleeding site, thereby you can control the circulation. And with related to airway, mouth breathing, and etc., you can think. And with related to splinting, you can get the cardboards or anything nearby, thereby you can do the splinting, thereby prevent further circulatory collapse. But most important is when you are unequipped, the first thing that you should do is ensure the scene safety. You are the first person there, so ensure the scene safety, that you are protected, the patient is also protected from further damage. The second thing is you should call the expertise. Okay, rather than you jumping and trying to save, first call the expertise and then you can get into the picture. So that is what you can do the second. And third, what I suggest is whatever is visible. For example, if the person may be having a broken tooth, the person may be having already throwing an epilepsy, the person may be having a cervical column which is not stabilized, the person may be having a deformity in the femur which is not stabilized. All these can be managed comfortably. For example, cervical, you can just put 2 cardboard around the axis of the neck and try to support it with any cloth or sling available next to you. when with related to the femur, just try to pull the femur and apply to cardboard or wooden boards, anything which is available near to you, and try to splint it accordingly. Okay, whenever there is a bleeding site, just give a pressure with whatever the material which is available to you. All by this mean, these are all the least possible things that you can do. You don't expect to save the life of the patient with no equipments. Okay, what you can do is only basic life support. So it is mandatory responsibility for you to ask for help from an advanced team. See, when one question is asked about the ophthalmic injury, I said I didn't say that I will manage the ophthalmic injury too. No, even being an advanced trauma life support surgeon, it is expected out of you to call for expertise. Okay, so don't be hesitant to call for help, and don't go with the confidence that you can manage any trauma patient with just bare hands and materials available to you. Always ask for
Thank
help.
you, sir. Thank you, sir. It was a very great session. Thank you,
Okay,
sir.
thank you. Thanks a lot. Hello. I
You can give a question, sir. We'll post it in the group. There's a
Yeah.
separate WhatsApp.
Okay. I just wanted to convey a fact, because I told during a oropharyngeal and nasopharyngeal airway.
Yes, sir.
Hello.
Yes, sir.
Yes, sir.
When the person is gagging, most of the time when you apply, the person will be gagging.
Yes, sir.
Okay. When the person gags, which means that all his reflexes are intact, and it is very difficult to do this in a conscious patient. But if the person can comfortably tolerate these two procedures, which means he is in high requirement of definitive airway, which is intubation. I just don't know how far this message has reached them. We shall put it as a comment. Okay.
Okay, sir. Okay, sir.
Okay. Thank you.
Thank you, sir.
Thank you, sir.
Thank you very
So
much.
the words are very clear. Patient who told oropharyngeal who can comfortably tolerate an oropharyngeal and nasopharyngeal airway are high likely to require an intubation. Okay.
Okay.
Thank you.
Thank you
Thank
very
you,
much,
sir.
sir. Thank you very much, sir.